welcome everybody. Thank you for joining us today. Iman, do we have anybody, do we have folks online? Okay, yes. That's terrific. So I'm going to do this at the start because I always forget. Please remember to complete your evaluations. And during the question period, I'll try to facilitate to make sure that we are able to have, to hear most people's voices. And introduce yourself when you're going to ask a question because the speaker may not know you or other people in the audience may not know you. So it's my great pleasure to introduce Doug Coyle. I invited him to come and speak with us. I think I met Doug.
Oh, we don't want to know so much. At least 15 years ago.
Oh, more than that. Well, you had just come off the plane. Like you had just come to Canada.
Okay, 22 years ago.
Yeah.
Okay.
So, and I've got to say, so I'll read you his bio in a sec, but I've got to say that Doug is one of the very few economists who I can actually understand, and who, you know what he does? He does like is it microeconomics? Because essentially, you know, it's not this big picture thing that, you know, things are, it's very concrete, and so it's, you know, the cost benefit, cost effectiveness, and so I found it really, really helpful to work with Doug, so it's, I'm delighted. Currently, Doug is interim director for SSMF, the School of Epidemiology and Population Health Medicine.
Public health and preventive medicine.
Public health and preventive
Horrible
medicine.
name, yes.
We didn't lose the...
We haven't lost preventive medicine yet, we're trying.
Yeah.
Politics.
Yeah, okay. So he's at OHRI, and he's also affiliated with the Centre for Health Economics at York.
York and in Brunel as well in London.
And in Grinnell, where you did your PhD.
Yeah.
So his thesis explored issues related to handling uncertainty and variability with respect to decision-making in healthcare. So Doug's research is multidisciplinary in nature. If you can get Doug on your team, you're very lucky because he works really well with everybody, and he's very easily understood. He has a lot of collaborations, and he holds a lot of leadership position other than his interim directorship. He's a member of the Scientific Advisory Panel of the Canadian Agency for Drug and Technologies in Health, and is a member of the Ministry Committee to Evaluate Drugs. So I'll say no more. So Doug, it's we will end at 9:30, and it'd be great if there was like a good chunk of time.
Yes, I've got way too many slides, but I will try and cut some off and just give you the sort of the main ones that are mainly the talking points more than anything else. So yeah, thanks, Simone. I mean, it's. I think it's. When I talk a little bit about what economics is, because I think Simone's right that there's a lot of people who talk economics that people don't quite understand, and I'll give you a couple of slides and just show you where I feel economics fits into this picture about trying to make decision making, but also show you where my sort of passion. It's kind of, my job is just awesome actually, well, apart from being director of the school, which is dreadful, but my actual research I think is awesome because it combines both a sort of passionate belief in a fair and equitable healthcare system with the nerdiness of getting to play with the data all day long. So it's actually a great combination without having to deal with the politics of school life. I've got no conflicts to declare. I don't work with industry. I did very much in the past, mainly when I was working at the OHRI, where there was more emphasis on trying to get sort of industry funding as well as grant money. But right now, the only conflict I've got is I do advise the Ministry of Health quite a bit in terms of coverage of drugs and other technologies as well. So I'm going to talk today about what is the role of economic evaluation in decision making. Give you a study that I worked on that was in what I can say is a difficult area, and then give you a little bit of the work in progress, what I've been trying to do the last 6 months while combining this job as director of the school. And it's taking a little bit more time than I hoped, but it's just a little area that I was kind of interested in and wanted to explore some findings before deciding whether or not to make it a big research idea or not. So, rationing healthcare. No one likes the idea of rationing. It's a word that goes back to the 1950s in the UK. Post-war Britain. If you're watching The Crown right now on Netflix, you probably know all about that sort of era. And but it really is about the idea that rationing means a fair share for all. I'm going to explain a little bit about healthcare and the specific aspects of the provision of healthcare, which means this idea of rationing really comes to the fore. So, most goods and services are rationed by price. And so every time you want to go out and buy baked beans, jeans, whatever, that's determined by our ability to pay for it is the way that we ration those goods and share them amongst the community. But market failure means that health cannot be provided through a market system. So there's many arguments about healthcare that we feel it should be equitable, it should be fair, and so there's really this sort of societal objective that healthcare should be provided through a market. But there's also a very convincing and very strong economic argument that healthcare is just not a commodity that markets work in. And I won't go into the 13 reasons today about why healthcare just wouldn't work within a market system, but there is also an economic rationale for not having healthcare provided through a market, not just a societal objective type or social choice argument. So given that, health interventions are provided to consumers at zero cost. And the problem is, if you provide something at zero cost, the demand for it far exceeds the supply for it. And therefore, we need to have some mechanism to decide what resources are provided and what aren't. And we can argue that, well, we should provide everything that's effective, but clearly we don't have the capacity to fund everything that's effective. When I try and explain my work to my parents-in-law, and my father-in-law is very adamant that we should provide everything, and then I say, well, you have to increase your taxes, and he says, I'm not having my taxes increased. And so that circular argument would have this imbalance, and those who shout the loudest will be those that receive the healthcare rather than those who are a little quiet. So there's 4 different ways. Actually, I'm going to explain why there's 4 there in a minute, because you're thinking there's nothing there that's economics. There's 4 ways that we could ration. And these are formal ways we could ration. We could ration by price. So we could just give up on a healthcare system that's funded through the public purse and just have price market. You could start to have private insurance companies like they have in the US. I'm not entirely sure what the US system is right now. No one really is. But anyway, there still is this preponderance of private insurance. It's quite fascinating because when you look at how much the US spend as a proportion of their gross national product on healthcare funded by their government, it's actually greater than what we do. So as much as they say they don't want to have a public expenditure on healthcare, they spend more money on healthcare provided through the public purse than we do, yet have coverage for a far smaller proportion of that patient group. And the costs of that are driven by the administration costs. So one of the biggest problems about having a private healthcare system is the excessively high administration costs associated with managing a system where you've got multiple insurance providers. We can prioritize based on clinical need, and this is what we do in crisis situations. You triage patients that emerge. There's some horrible catastrophes occurred. Clinicians go in, they try and prioritize those patients who could be dealt with now, those patients who could wait, and those patients for which there is no hope for, and they move on to other patients. And that works fine in a catastrophic situation. It wouldn't be the most sensible way to deal with rationing on a day-to-day basis, because those patients who could recover quickly but may not be the sickest would always be at the end of the line. Another way would be to prioritize based on looking at those patients with the highest net gain. So instead of looking at those who are sickest, try and look at those who would benefit most from healthcare. And that would work, except for the fact that it ignores the issue of the cost of those healthcare. So if you can find someone, I'm going to give you an example in a moment of a healthcare intervention that's very effective, but exceptionally costly, and therefore how do we make that trade-off? So the final thing I suggest is that we maximize based on population health. And everyone likes the term population health, so I use the term population health. But basically you choose the interventions which gives the biggest return in terms of maximizing population health. And there's a lot of feeling that that is the societal objective of the Canadian healthcare system. There are other concerns that come into play with certain decisions, so there's definitely equity concerns about specific minority groups. But I think most decision makers would argue that the maximization of population health is a reasonable objective, which is kind of good, because that's exactly the same as cost effectiveness. And so when we think about trying to employ economics into these decision making, what we're doing there is trying to balance health gain against cost, with the presumption that if you do that, the mathematics show you it's true, you will maximize population health. So if we can agree that population health is what we're trying to achieve, there may be other objectives, but it might be one of our main objectives, then cost effectiveness has a clear role to play. So why do we need economic evaluation? Well, there's a lot of pressure on healthcare budgets now. There's many reasons why that happens. It's down to the changing in demography. We're all getting older. That's a good thing if you're getting older. We all don't want to not get older, but the problem is that we look at how healthcare expenditures are transferred across your ages, and clearly you spend far more dollars in healthcare now, or as you get older, than when you were younger. And so we know that roughly it's about $6,500 per person we spend in healthcare in Canada. Clearly, it's much higher when you're in the 70s and 80s in your life than when you're in your 20s and 30s. And so change of demography is one factor. The other factor is all the new technologies we see now cost a lot more. If you look at diseases like stroke prevention and atrial fib, we got a huge benefit by just giving patients aspirin. Then we gave patients warfarin that costs a bit more and gave a little bit more benefit. Now we give patients drugs like dabigatran and rivaroxaban, which give relatively the same benefit that warfarin gave to aspirin and aspirin gave to placebo, but the actual absolute benefit is much smaller. So every time we've got these new technologies that appear, the absolute benefit for them is much smaller, and the costs are much higher, and therefore the pressure in the healthcare system increases. Economics is really about the idea of making choices, difficult choices with scarce resources. So if a health service spends $1 or one resource on one thing, it automatically denies the ability to provide another service. And so one of the biggest problems about economics is we have to place the value of the resources in a common way, and we use dollars, and then if everyone thinks it's all about costs, the costs we're really concerned about is what's the population health foregone by investing in one area rather than another. And that's really what the underlying question is if we invest our money in this area, do we get a better maximization of population health than if we invested in money in another area? And so this is what we can term the concept of opportunity cost. If we spend money in one area, we automatically deny some other individual health care, and the question really we've got is how much are we willing to deny one individual based on the benefits that another individual receives? So economic evaluations are the tool that we use to help inform those decisions. Now, they're not the same or not a replacement for other factors. Clearly, politics plays a major role. There's other concerns that come into it. But the key thing is it's designed to inform decisions. So we're not about testing hypotheses, which is a traditional type of clinical research or epidemiological research. We're actually designed to try and find expected values, to try and inform decisions so that the decision maker can address the decision that they're facing. So economic evaluations can't be done in isolation of that decision. You've got to specify what the decision is you're trying to inform. The idea of just doing economic evaluation as a means of an academic exercise is all fine and dandy, but has no real relevance then to a decision maker. So economic evaluation is a comparative analysis of courses of different events, of different interventions in terms of their costs and consequences. So we can compare a current program to a new program. We look at the cost, the value of the extra resources used, and then we look at the consequences of the value of the health gain. And what we have to make a decision about is, are the resources that we've consumed, is that the best way we could use the resources? Is there some other way we could spend that money to maximize our population health? And if so, then the opportunity costs of that intervention are too high, not in terms of the dollars spent, but in terms of the health benefits that we would forego by not providing those other alternative healthcare interventions that we can no longer afford. And I'll show you an example of that with the first example that I'm going to show in a moment. Now, a lot of people argue that there's a sort of a contradiction, or there's a conflict between cost effectiveness and economics with ethical and equity concerns. And so that's a very common argument here. And unfortunately, many of us fall into the trap. I've talked about the trade-off between efficiency and equity and ethics before, and I've fallen into a trap that doesn't actually exist. And I'll try to explain why. Economic is actually based on an explicit equity statement. And so that's one of the things that we're very clear up front about, is that we have an explicit equity statement, which is that a health benefit gain is of equal value regardless of which individual receives that benefit. If society has an alternative position, so if society believes that they want to weigh benefits for some individuals more than others, then that's okay for society to do that, and then we'll change our maximization that we're trying to achieve. Now it's trying to maximize weighted population health. The society has to have that difficult decision and difficult discussion then about what that alternative equity position is and what members of the society's health benefit are going to be weighted more highly than others. And if society doesn't want to have that decision, then society is ignoring their actual requirements and their duty. Because it can't say we don't like the idea of weighting all health benefits equally, but then we don't want to have the discussion about which health benefits should be weighted high. So cost effectiveness is actually based on explicit consideration of what we call collective ethics. And that's understood or underlined by the idea, is it ethical to fund a treatment that denies more health benefits to other individuals because we can no longer afford their treatments? So the ethical statement is that by making efficient choices, we maximize healthcare, and individuals all have the same right to access healthcare with the objective of maximizing population health. If we make inefficient choices, then we don't maximize population health, and we're implicitly saying that someone's health is worth less than someone else's health. And if we want to do that, that's fine, but then we should actually have the discussion about whose health is worth more than other people's health. And this is really a conflict between individual and collective ethics, and not to be down on Canadians, because after 22 years I should start thinking of myself as a Canadian, we have a lot of focus here about individual rights and individual ethics, and far less about collective ethics. And collective ethics, when you're talking about a healthcare system funded by a public purse, then probably collective ethics should be what's a priority. And if we want to focus more on individual ethics, then it really undermines the whole idea about why we have a publicly funded healthcare system in the first place. If we have an alternative equity position, that's fine. Economics can adapt to that. We're just assuming that it's maximizing population health because that's what we think society wants. If it's something else, then that's fine. It should be evidence-based. Many suggested criteria are not borne out by population surveys. So people have done work to try and see, do we consider people who are young higher than people who are old? People who are old higher than people who are young? People from specific ethnic backgrounds, higher or lower, people with life-threatening diseases compared to chronic diseases. They've done surveys like that, and in most situations, when you ask members of the general population, they don't put preference over one group versus another. What they're trying to do is maximize population health. So it seems to be that that's what general population actually wants. So if a society doesn't want that, that's fine. It doesn't preclude consideration of opportunity cost. But it does require an explicit ethics statement about which individuals should be given greater priority in terms of grading weight of their health. So, I'm going to talk to study now about a drug called the Soliris. Anyone heard of Soliris? Probably because it's been in the news a bit. It was in the news about 3 or 4 years ago, so probably not anymore. Anyone know what paroxysmal nocturnal hemoglobinuria is? Thankfully it's called PNH, so I'll start calling it PNH. Anyone know what that is?
Oh, we've got lots of clinicians.
Oh, you do have it.
They all know.
I know it's a rare disease, but I know it's fairly
It's pretty rare. It's pretty rare.
pretty rare. You have to really treat them on a daily basis.
We heard about it
So-
in med school.
Excellent. Okay. So we did a study for this. Myself, Matt Chan, and Gerald Evans were actually part of a working group for the Ministry of Health to advise them about funding of Solaris. And after that, we did some further work to try and actually look at what the real economic impact of funding Solaris would be. So this work came out of a working group, but was independent of the working group. So there's no real conflict with it, but it's important to state that that's where it came from. So PNH is a rare disease. It's due to a missing gene called PIG-A. It's rare, population prevalence of about 1 in 63,000, which is rare, but it's not that rare. I mean, I always think, well, what do we mean by rare and we want special cases? That's 10 people in Ottawa with PNH. To me, it's like having the flu in July. It's not really so rare that you never ever hear about it. It's interesting, and I need to read these slides because I'm not a clinical expert, because its name's wrong. Paroxysmal means it suddenly appears, and it's not true, it's ongoing. Hemoglobinuria means you have brown pee, basically, but only about 75% of patients don't have hemoglobinuria. And the idea is nocturnal is because the symptoms happen at night, but that's not true either. So it's got a lovely name, but the more they researched it, and this is the problem with rare disease, they found out that actually the name doesn't match, but it's still called PNH. It's not a great disease. I mean, rare diseases aren't. Mean survival about 14.6%, 14.6 years. Most people die from thrombosis or renal failure. You do have problems in your blood in terms of myelodysplastic syndrome and acute leukemia, but approximately 25% of patients survive at least 25 years after diagnosis just on blood transfusions, and 15% will spontaneously recover. So it's bad for some patients, and for others it becomes quite just a sort of regular chronic illness. So I'm not going to go into the great details of the model because I don't want to use up all my time. But we developed a model to try and look at the 6 distinct components of the disease, and then from there we tried to look at what the impact of Solaris would be, because it is effective, but many of the things it's effective with, we have other treatments. And one of the problems with rare diseases is we tend to spend all our money on the magic bullet, while many of the complications of the disease can be managed quite adequately by existing therapies that are common and a lot cheaper. So we looked at thrombosis-related problems, we looked at marrow-related problems, we looked at hemolytic anemia, we looked at iron overload, which is a common problem with patients who receive too much transfusions. It's not a common problem in patients with PNH because the nature of the disease means they do not have or suffer from iron overload. But I'll explain one of the complications of treatment in a moment, which makes this an important area to model. So we know that Solaris reduces the complications, the main ones that cause the disease, thrombosis and renal complications. It improves quality of life because it makes patients transfusion independent. And there's lots of evidence that shows that patients who are transfusion independent have improved quality of life. It doesn't make everybody transfusion independent, but it makes a proportion. There are risks, meningococcal infection. I hate saying that word, but I got it out there. That happens because basically you're doing things to the complement within the individuals, and therefore they're at risk of infections. And so you need to vaccinate them almost on a yearly basis for everything over and over again because they've got no complement to build up immunities. But the one problem is that if you have PNH and you don't treat it, you can't develop iron overload. If you have PNH and you treat it with Solaris, the problem is that if you still require transfusions, you can now have iron overload. And iron overload is not a particularly nice thing to have. It's very expensive to treat, and it's not got great consequences. So it really is a drug that you want to take and hope that it's 100% effective. Otherwise, any of the benefits are probably going to be outweighed by the adverse events. There will be cost savings through complications, but not from the iron overload. So if you're getting iron overload or a high proportion have iron overload, then it will actually cost more if you treat them with Soliris than they would do without Soliris. And Soliris itself, anyone remember how much Soliris costs per year per patient? 35,000. Anyone higher? Bill? $500,000. Spot on. Yes, over $500,000 per year per patient. And that's not the cheapest drug. We're now dealing with another drug in another area which costs $3 million per year per patient. Which one's that? Expensive. It works though. So we talked about how it does. Yeah.
Which one's that?
I think it might actually be Soliris in a different clinical area. Yeah, this is not a nice company. It's not a nice situation to work in. Got me tape there. So it works. So when we're looking at quality gains, which is quality adjusted life year or life years gain, this is a big benefit item. And we don't see quality gains of 2 and 3/4 years typically in our models. So this is something that clearly works. Problem is, if you look at costs, over a lifetime, it's $5.4 million per year. So it's a huge incremental cost for a very solid quality of life and life expectancy gain. So the incremental cost per quality is about $1.9 million. Typically in Canada, we've always gone with the idea that if it costs less than $50,000, the opportunity costs aren't sufficient to say that we shouldn't fund it. That's probably too high now. We probably need to bring that figure down. And it's one of those horrible things to try and explain to someone. The reason we have to bring that figure down is because we're more efficient. Everyone thinks if we're more efficient, you can spend more per quality gain. It's actually the reverse. The more efficient you get, then the cost of denying something is actually much higher than it was before, and therefore you have to bring the threshold down. I know all of you are thinking, what's he talking about? But just believe me. So it's $2 million. Well, often what we look at is what the price reduction required. So that's based on the current price. That's based on the price reduction, what it'd have to get to. You can't quite see that. But basically what we would need, oh, it doesn't show anywhere, is a 98% price reduction. I don't think they managed to achieve that. Actually, this is a company that wouldn't negotiate on price at all. They didn't quite get the 98%. And there's a lot of negotiations now. That's a typical way that ministries of health work, is that they negotiate prices for all the technologies they deal with. And the great thing that we had a Transparent Drug Act that was put in place 12 years ago, and one of the key features of the Transparent Drug Act was all these negotiations would not be transparent. So we don't actually know how much we actually spend in all these technologies now. So what was the impact? Well, I think you all know now, is that we actually fund Soliris, despite the evidence that it's not a particularly good buy. And the most worrying thing about it is we actually fund it in a far more liberal population that was ever covered by any of the clinical trials in this area. So in the clinical trials, there was much more strict criteria about it, but now it's actually pretty much anybody with PNH can get access to Soliris. So some clinicians argue it's still not, we can't get everybody on this drug, but there's more people now on the drug or a wider patient population is eligible for the drug that was actually ever studied by the clinical trials. So what's the opportunity cost? So this gives you some context of why maybe this wasn't the best decision. Typically, I said the threshold is 50,000. We should expect about 108 QALYs from an intervention that costs $5.4 million. So basically, the cost isn't the $5.4 million, is that there's probably other things we could do in our healthcare system that would generate an additional 105 quality adjusted life years. So that's a health benefit for God. Another way of looking at opportunity cost is looking at other things we could have funded. So based on the prevalence of PNH in society and looking at the population of Ontario, we reckon, and the government won't tell us how much they're spending on Soliris, but we reckon they're probably spending at least $9 million per year on Soliris. That's for about 18 patients. We could have one public health nurse go and visit every newborn in their home to check the surroundings, give advice to the mother. We could pay for 200,000 ambulance co-payments. I think it's scandalous in Ontario that we charge people to go and go to hospital when they need to. The idea that somebody might be contemplating whether or not I should go to the hospital because I've got to pay $120 co-payment regardless if it's necessary, it's just awful. We could pay for physiotherapy. That's a beef of mine, given I've got a chronic hip condition and I have to go and see my physiotherapist once a month. If I didn't, I would need a hip replacement. Clearly, it'd be much better to just keep me going to my physio than it would be to give me a hip replacement. But, you know, hip physio isn't covered by Ontario Health Plan. We could support people with mental illness in the community. We've downloaded everybody into the community, and maybe more controversially, we could fund 4 supervised injection facilities. There's lots of things we could do with that $9 million that we're spending every year on Solaris. That's the cost of Solaris. It's not the $5.4 million, it's 105 colleagues we've forgone, it's all the other things that we could spend that we're unable to spend based on the fact that we've got limited resources. Now, there is arguments that people see, and you can see there's lots of rare disease societies now. There's a Canadian Organization for Rare Disease, CORD, heavily funded by industry. Most of these, we always talk about these as not grassroots organizations, but astroturf organizations. They're sort of fakely developed by industry to try and push for their products. There wasn't any funding for these groups when they didn't have drugs, but now they have drugs, industry come to the forefront. So rarity is argued as a value concept. So the idea is, you've got a rare disease, supposedly it costs more to produce the treatments for it, and therefore we're not going to be able to provide very expensive drugs for rare disease. The idea that we don't treat patients with rare disease is a misnomer. Clearly we treat patients with PNH, with blood transfusions, we treat them when their complications arise, we put them on warfarin to avoid thrombosis events, so we're definitely treating them, we just don't want to fund, or we do fund, the magic bullet. Do you accept that rarity has some value, that we would put more value on a patient with rare disease than a patient with a common disease? And that's the question you need to address. Everyone's shaking their heads. It's good to ask you anything more. But it's a difficult question. If you really think, well, rarity, it's unfair, how much fair does it need to be? And so, I mean, that's a difficult question. How much more value should be placed on an individual with a rare disease than a common disease? And if that's a horribly difficult question you want to address and you don't want to, that's fine, but you can't say rarity is a value concept that we rate highly unless you want to have that difficult discussion about how much. And as an economist, I don't care. I mean, I have personal preferences about what we should put our money on, but it's a societal decision. So if society does think a rare disease should be given priority, and therefore the health gains for someone with a rare disease is more important than the health gains of someone with a common disease, then that's okay, but you need to be able to ask how much more do you want to place. And in this case, you'd have to say that a year of life gained for someone with a rare disease should be worth at least 40 times a year of life gained for someone with a common disease. And that's the trade-offs that governments have to start thinking about, because that's what they're doing when they're making the funding decisions to fund in the area of rare disease, demonstrate the opportunity costs associated with it. The implicit decision basis they've got is that they're saying someone with a rare disease is worth at least 40 times in terms of their health benefit than someone with a common disease. And so the big issue is that something society actually truly and utterly believes. Please.
I'm assuming you gave this presentation in essence to the ministry, and why did they then go ahead and decide to fund it? There's sort of a disconnect, because the argument makes perfect sense, and then,
I don't look so good
we
in
turn
the
around
papers.
and you have the decision to fund. Like, how does that happen?
Because they can't present this argument in the way that they can, that in the media to get people to buy into it. It's very funny because in the UK now, if you go on the Guardian website and you see any discussion about drug prices and you go in the comments, you get lots of people chiming in saying we shouldn't fund this because the effect's going to be we're going to deny other health care and it's wrong. You don't get much of that dialogue here right now. And we need to start trying to work at persuading people of the consequences. Because if you talk to people one-on-one, they get it, but that's not what the media coverage is going to do.
Is it politically not acceptable because individuals with these rare conditions have names and faces, whereas the alternatives, like having an extra public health nurse, it's not clear on which person was helped. So there isn't the same. It doesn't project as in a debate in the public sphere. The politicians can't cope with, just can't manage to say no to when it's a person, but when it's an overall gain that isn't identified to a particular individual, so they're not able to express it in the same way.
I've tried to start using that game a little bit, because I presented at the House of Commons last year about the National Pharmacare, and there was one of the ladies from a disease site lobby group, okay, funded by industry. It's the Canadian Diabetes Association. We always call it the Canadian Front for Industry. And they argue in a way. I want to tell you about Bob. Bob has got this situation, and Bob needs this, and Bob needs that. And the way I've started to do it, try and interact, is try and say, well, I'm going to talk to you about Bob, Brian, Derek, Donna, and start to say that you need to start presenting the dialogue back, so that you actually say, if people are going to use vignettes as an argument, and it's very, very common now, you need to present vignettes back. And then that's the only way to win those arguments, because they are designed to tear at your heartstring. You don't want to deny the poor kid intervention. We'll start talking about other children, and start talking about other things that we could do, and start talking about, you know, the common things that we could do. Start talking. I mean, I love using the ambulance scenario. I love talking about, there's this person in Toronto living in subsidized housing. Their kid has an incredibly high fever. They're not sure what to do. They think they should call an ambulance, but they don't have ambulance. Give them those scenarios, because those are real scenarios, and that's the sort of things that we're deciding not to fund, because we're pushing too much into the area of for-profit medicine, because those who want for-profit medicine have the money to lobby far more effectively than other areas.
Yes.
I think part of it is we live too close to that other country.
Absolutely.
And when you think about it, when you look at the Commonwealth Fund and where we actually live, you know, we're just above the U.S. in our outcomes, and part of this is, in fact, David Naylor said, you know, we think we're better than the U.S., but we're not better than certain parts of the U.S.
Yes, very much.
And so we have some big issues around, do we really buy into publicly funded healthcare? And it's that piece about the individual rather than the population health that really sticks out, and I think it is part of our ethos. And the victimization, I mean, I renamed CBC, you know, victim radio, because it's always about the victim.
Yeah, always.
Just don't forget to introduce yourself.
I'm Diane Delbert.
Yeah.
I mean, well, we
Yeah, right there and then at the back.
I'm Sharon Johnston, and I just was responding to that politicians can't tolerate injury to Bob or little Julie. I was doing my law studies in England when this debate was playing out in the courts and very publicly, with very open discourse. Part of the reason why I went into medicine is it's the public that reacts very strongly, and we don't have public education. Politicians need to stay in power to do all the good things they want to do. And if funding for little Bob doesn't stay in power, they'll continue to do it. It's the public's reaction to Bob, not necessarily politicians
very
can't
much.
tolerate it.
Yeah, that's a
And
really
we're
good
quick
point.
to blame the politicians, but it's our discussion.
Absolutely, the politicians respond to what the public want.
Yeah.
And it's interesting because you bring up the UK. When NICE came into being, it's probably what you were talking about, and they started to have hard, fast rules about funding, it was horribly unpopular. But now, 15 years, 12 years later, public opinion sways. I mean, it's something you have to have the guts to put in place and do, and then watch how public opinion changes as they start to realize, and you make clear those trade-offs and those decisions you're making, they start to realize what the concept is. But it requires a bit of effort, and it requires someone to have the wherewithal to say, this is actually better for you, and we're going to explain to you why. Right at the back.
I'm Richard Manasco.
Okay.
We tend to frame this in terms of countries and ethics of large bodies, but is this not really a decision that's made one formulary at a time?
It is. I mean, we're just talking about drugs. I mean, I gave you an example of drugs, but these techniques are used in all types of decision making now. And so, yeah, but we have got a provincial healthcare system in Canada, and it's an accident of 1867 that we're still trying to deal with. And so we know that all these decisions are taken one-off. They're more consistent now than they ever were. And so we're starting to work towards having a lot more consistency. There's a pan-Canadian pharmaceutical alliance who negotiates with drug companies. And so there's an attempt to do that. I think we should move towards a national formal care strategy. It would be much more equitable across the provinces. But you're right, there is a concern, and this is where the rare disease thing becomes really quite important, is that provinces are trying now to compete with each other. You know, when the Ontario minister went on to congratulate herself, basically, for funding Soliris, it was made in the context that some other provinces weren't yet, and aren't we wonderful? So that type of competition isn't particularly healthy.
Well, my question, sorry, is whether or not there are actually best practices that are published somewhere by the Association of Formulary.
About how to make decisions
councils.
or which decision to make?
So in terms of deviating from what would be considered to be best practices for what to include in the formulary and what not to include in the formulary?
Yeah, no, there isn't. I mean, we can look at certain systems and how they make the decisions and which ones we think are reasonable. I would say that the Australian system, PVAC, was very good. It's gone downhill in the last few years. Not because I'm Scottish, but I think the science system in Scotland is excellent. NICE isn't bad. It's a little bit a pawn of political masters. And so we can look at how other people have done it. Part of the problem with our provincial system is that, you know, you've got variance across provinces in terms of capacity to make these decisions. So it's very hard to make very educated decisions in areas like PEI when you've got less capacity in terms of people qualified to help. Saying that, I mean, I look at how places like Nova Scotia made decisions, and I think they're far more transparent and far more effective than some of the larger provinces. But I think the key thing is we need to have more transparency. I can't tell you how good Ontario is doing in making decisions right now because they don't tell us. And so that transparency must be the first thing that we actually are able to do. Then we can start to at least judge the decisions that they're making. If we don't know what the decisions are they're making, we can't judge whether or not they're good or bad.
Do you want to entertain more questions, or do you have a few slides to finish?
I have a few. Well, I've got a whole set of other slides, but I'm going to actually.
Because if you were happy, I'm going to raise one question. Have we looked at the cost consequences of not using Soliris? So.
Oh yeah, I mean that's built into an analysis.
Oh, it is.
So
that
the analysis
$500,000 a year is drug minus.
$500,000 a year is not just drugs. So if you look at the numbers. Eventually. That is a cost of managing someone with PNH over a lifetime if Soliris wasn't available. And so that, and the sad thing is, to be honest, is if you take out the cost of Soliris, it's still higher for patients with Soliris, mainly because of the iron overload. Iron overload is exceptionally expensive to treat. And even a small proportion of these patients requiring treatment for iron overload swamps any of the cost savings that you got from avoiding blood transfusions and warfarin, which, to be honest, aren't very expensive to treat. And therefore, it's not a great therapy in terms of saying you're going to save lots of money despite the costs. So I was going to very quickly introduce my work in progress. And that was really looking at the area of obesity, because I'm a little concerned that we've got an issue in Canada, that we're getting more and more people who are overweight. And really, I just wanted to start to explore what is the differences in long-term outcomes in healthcare costs based on your body mass. And so this is very early work in progress. You know, we hear about obesity epidemic. It's I'm not an epidemiologist, but I know epidemiologists don't like to use the word epidemic when it's not an epidemic. But we know there's an issue. We know that 31% of Canadian kids are overweight, and maybe it's just I grew up in impoverished Scotland in the 70s that no one in my class was ever overweight, but now it's an issue. And we can see over time that the rates of obesity are increasing in each of the provinces in Canada. And we know that 2/3 of Canadian adults are now overweight or obese. That's unclear, not very helpful, because I'm overweight, and no matter what I can do, I can't lose the 5 pounds that would make me normal weight. So it's just some categorizations of this is just unfair. But we do know that 2 times as many people are now obese than they were before, 3 times as many children since 1980 are obese. And so Senate of Canada has talked about the fact it increases healthcare costs and increases morbidity. And so really what I wanted to do was start to explore the idea of modeling people's lifetime progression based on their body mass. So the idea is we've got data out there that shows that if you're 25 and your normal weight, what by the age of 30, what is your likely body mass category going to be? We've got data on mortality associated with body mass, we've got data on quality of life based on body mass, and we've got data on healthcare costs based on body mass. So I could create a model and say, let's look at 25-year-old women today and tell you what the different long-term lifetime outcomes are going to be based on their current body mass, as a tool for us then exploring the impact of interventions. So this is very early days yet, but basically the idea was that we present results for 25-year-old women who are currently underweight, normal weight, overweight, or obese class 1, 2, and 3, and then look at how they transition over time. So basically start at normal, you can die, you can go under, you can go over, you can stay normal, and then you just keep moving through this on a 6-month basis. Oh, skipped way too much ahead. This is progression of a 25-year-old. So everybody starts off in normal weight. As we grow old, most of us start to become overweight, although I'm not a woman, the same applies to men. Some people become obese class 1, some become obese class 2, some become obese class 3, and everyone eventually dies. But that shows you the progression of a 25-year-old woman based on the best Canadian data we've got right now about how they're going to change. And one key thing to think about as we talk about the fact that people need to lose weight, maybe the best thing we can do is actually maintain our weight. And that's one of the things I tried to explore with this very early work. So really I want to look at how does life expectancy vary by body mass? What's the incremental benefits of an immediate change? What's the incremental benefits of an immediate change and sustaining that change? And what is the difference between current expected outcomes if you can sustain your body mass rather than what that natural progression in body mass would be? So I can't give you all the results right now, but let's go forward to the discounted values. You can start to see that there isn't much of a difference in life expectancy. I mean, there's a little bit of a difference. If you're obese class 3 right now, you're probably going to live 1.4 years less than somebody who's normal weight. Remember, this is driven by the fact that a proportion of those who are normal weight don't remain normal weight, and that's what's really pushing these results. And I'll show you the difference in a moment. If you bring in QALYs into the thing, you can see the difference is much greater, and that's because of the quality of life effects of an individual who is obese is really quite bad, and you can start to see. Now this is a fascinating one. Costs, almost no difference. You keep thinking that obesity is, solving that's going to save our healthcare costs, and there's a little caveat to that, that I didn't have costs for each of the classes. It's probably much higher in obese class 3 than obese class 1. It's average cost for obese, so it may well be that there's going to be a spike there, but it doesn't seem like there will be, because obese class 1 is the same as normal and over. Major issue there is 2 things. One is, if I'm normal weight today, I won't be normal weight in 10 years' time or 20 years' time. So a high proportion of 25-year-old women today, when they're 65, their weight or body mass may not be that much influenced by what it was at 25. And so the cost difference, which occurs mainly as you get older, are going to be diluted by the fact that we vary in our body mass over time. And also the fact that somebody who's obese dies earlier means you save the healthcare costs because there are 1 year less of healthcare costs to accumulate. So maybe not what we were quite expecting. This is the immediate benefits of changing your body mass. Let's look at it in terms of QALYs. If you can reduce your weight from overweight to normal, you'll gain 0.8 of a QALY. The biggest gain, oddly, is from getting your weight down from obese class 2 to obese class 1. And the problem, I think, with obese class 3 is that people with obese class 2 almost never really get lower weight. And so if you can move from obese class 2 to obese class 1, there's a potential that you actually have significant health benefits. Someone who moves from obese class 3 to obese class 2 is probably going to stay in obese class 2 for most of their life, if not go back to obese class 3. So it's a problem about the fact that you really need to get down to obese 1 or overweight. Yes, Al?
Sorry, Doug, quick, Al Mayhew. Can you give me, what's 3, 2, and 1? Is there BMI?
Oh, yes,
Those are
BMI, I can't remember
Sorry.
them. No, it's, I think it's over 30 for obese class 1, and then it's over 35 for 2,
Okay.
40 for 3.
Yeah.
It's
Thank you.
pretty hefty, yeah.
Okay, that's good.
This is the healthcare costs. So, not substantive changes, but let's have a look now at what happens if we not just change our body mass, but then can sustain it. And this is what I think is more interesting, is you can start to see this is where the benefits occur. If you can reduce weight and keep that, so all those quick fix that we're advertising, every time I drive the car, I have to listen to Dr. Bernstein's 30-day cure without exercise, and never lasts. You need to do something that's healthy that you can sustain. And that is really quite an interesting message to give, that it's not much point losing weight and not having a long-term plan about how to sustain it. Clearly, and in terms of costs, we start to see some significant differences as well if you can help someone to lose weight and sustain it. There is some evidence to say as well that even just sustaining the weight you are now is worth a lot. So you can see here, there's about a 1.4 QALY gain if you're normal weight now, just working at staying at normal weight. Even if you're overweight right now, just staying at overweight is actually a much better thing for you to do than worry too much about losing weight. It really is about trying to sustain yourself at a reasonably healthy weight, and finding a long-term plan is probably more important than short, sharp shocks. And we all know that if you start to maintain your weight with a healthy plan, you tend to lose weight over time anyway, and so you might move categories anyway. But it's clear that we need to have something that's more than just a quick, sharp shock, but is also something that allows us to sustain these benefits long term. Yes?
Does this model take into account any benefits or harms of the intervention to sustain
No,
weight?
I haven't looked at anything to do with interventions here. This is just saying,
By intervention, I mean how you maintain your weight.
Absolutely.
What it is you do. We call that an intervention.
yeah, I haven't looked at any. All I've looked at here is saying, well, if we could do this,
Okay.
this is a difference in outcomes. The next stage would be to start to look at the evidence about interventions and see which ones work, which ones don't, what adverse events it would be. All I'm doing here is saying that if we could find an intervention that has no adverse events and can reduce our quality-adjusted life, and you could reduce from overweight to normal weight, this is what you would gain. It gives us a template then to create a model to start looking at the interventions that might actually achieve it. So this is very early work in progress. It's trying to look at, in a sense, I said we're not a hypothesis discipline, we're trying to look at those hypotheses that would say, well, where is the potential at least of getting health benefit? Then let's look at the interventions that would actually drive this. So I'm running out of time, so that's just where I am right now. Anyone interested in this area, please email me or chat to me about it. But the big thing is there seems to be more benefit by changing and sustaining body mass than any short, sharp shocks. And so that's just something to be really clearly aware about. General conclusions, some form of rationing, explicit or implicit, is inevitable. It happens already. I'd rather it was explicit. I'd rather it reflected societal values. we need to have the discussion about that. Not concerned just about equity, efficiency, but also explicitly considers ethics and equity. More commonly used, and we need to have high quality studies as well. And I have no time left for questions.
So we can take actually one question,
Obviously.
and then Doug, you're going to be around.
I'll be around for
break.
5 minutes, but then I need to head back for
Yeah.
a meeting.
Yep, thank you. Is there any question?
I'm really interested in the obesity one. I hear you haven't gone into interventions, but one area that really is the same as Solaris is bariatric surgery.
Yes.
It's hugely expensive, but I don't think people understand the lifelong consequences and adverse effects of this, and it's very popular and very expensive.
And the opportunity cost of not doing
Yeah.
alternatives
Yes.
with their own
Yeah.
benefits.
And the sustainability angle, I think, is a big
Mm-hmm.
issue there. I really don't think that, I mean, we talk about the fact that I can't get to normal weight. I used to be about 45 pounds heavier than I am now. I'm saying that to show off, but I didn't do it, and I did it over time, and it's a struggle. And people, like I have children now who say, oh, it's easy for you, and it's not. Anyone who's trying to maintain their weight, it's always a struggle. It's always choices to make. And it's a sustainability issue. And if you don't have something that actually works, that you can fit into your lifestyle, and all these short, sharp diets that people go on, they're not sustainable. You can't keep doing that for the next 50 years. And so you really need to start to think about something